Welcome to Legal Nurse Podcast. I'm Pat Iyer. This is a podcast that has been sharing content with you, tips, strategies to help you in your business, which I started in September of 2016. We are now in our 9th year, and we love sharing information with you to help you in your practice. Mark your calendars. Our next online conference is taking place February 27, 28, and March 1 of 2025. We have our act together. We've got this conference planned for you and available for you to reserve your seat at the lowest rate by going to lnc.tips/February 2025 virtual. That link again is lnc.tips/February 2025 virtual. There's no spaces in that link at all, particularly between the February and the virtual. lnc.tips/February 2025 virtual. We'd love to have you join us at that conference and get the benefit of the expertise of our speakers and our topics, all designed to give you the knowledge, the support, and the networking that you need as a legal nurse consultant. And now, let's get on to the show. Welcome to Legal Nurse Podcast. I'm your host, Pat Iyer. This is the 8th year of Legal Nurse Podcast, and we are so pleased to be able to bring you these updates about legal nurse consulting, liability, and clinical issues that help you in your legal nurse consulting practice. Be sure to go to our website, Legal Nurse Business, and take advantage of our free reports and to stay in touch with us. I'm pleased to introduce you to our guest today, who is a registered nurse with over 23 years of experience in a variety of healthcare settings. She has clinical experience most recently in the area of IV home infusion, and she works as a legal nurse consultant, sharing her knowledge with plaintiff attorneys and defense attorneys. Our guest is Shannon Fenimore. Shannon, welcome to the show.
Thank you, Pat.
I know that some of our guests are going to be thinking, home IV infusion, what is that? Do we really give IVs in the home setting? Can you tell us what that means?
So yes, this is fairly common. So your home IV infusion involves administration of IV therapy in a patient's home. And this can include treatments as antibiotics, chemotherapy, hydration, blood products, and biologics, and also nutrition. Many chronic illnesses and diseases can require ongoing weekly infusions. For instance, alpha-1 patients that require prolactin, which is on a weekly basis. The therapy is typically managed by a healthcare professional or a trained caregiver, allowing the patient to receive necessary treatments in a comfortable, familiar environment.
So that leads to my next question. What would trigger a person or the healthcare provider to decide that this is an appropriate setting, as opposed to a person going to an outpatient clinic, for example, and receiving those IV fluids and medications? Because I've seen it done both ways.
Right. So home IV infusion is used when the patients require ongoing IV therapy, but are stable enough to not need continuous hospital care. So a common circumstance include long-term antibiotic therapy for infections ongoing, chemotherapy for cancer treatment, hydration for dehydration, and parenteral nutrition for those who cannot eat, and pain management in a palliative care setting.
I know that in the hospital setting, we frequently use veins in the hands and the arms for administering IV therapy or IV medications. Is this the same type of access that's used at home, or is something different used?
Yes, those type of accesses are used in the home. So the types of access would be, first of all, a peripheral IV catheter, which we all pretty familiar with, short-term access that typically is placed in your arm or hand. Next would be a PICC line, which is a peripherally inserted central catheter for more of a long-term access. It's inserted into a large vein in the arm and then threaded towards the heart. And then a central venous catheter, a CVC, is a direct access to the central vein that's often used in more complex and long-term therapies. And then lastly, patients that have implanted ports, which is a small implanted device under the skin connected to a vein for long-term therapies such as chemotherapy.
So it sounds like a variety of devices, and some that are designed to be indwelling for a longer period than a peripheral IV, which has to be changed pretty frequently.
Correct.
When these IV fluids and medications have to be administered, who is the person who does that?
So typically, the home infusion nurse going to the home would hang that. So it would be a home care nurse, and they visit regularly to administer the therapy and monitor the patient. But however, if the patient or caregiver is adequately trained, they may also be responsible for hanging the IV between nursing visits.
Have you encountered situations where it was difficult or impossible to train a family member to take this over?
It can be challenging. They're just not as comfortable if they don't have a healthcare type background. And, if it doesn't seem that they can really learn this in a proper fashion, you don't really want the risk involved. And that's when a home care infusion nurse would continue to come back in. But it can happen. I've had patient family members, a few that are non-clinical, that have really taken on that task and learned proper care and maintaining that device. And sometimes they have a nurse friend, neighbor, or family member that will come administer for them.
I'm thinking of a friend of mine whose husband was diabetic and went into renal failure, and they attempted to teach her how to do home dialysis. She's a bright woman, but there was something about learning all the steps that completely floored her. And she tried, but she couldn't put it together in her mind. So her husband went to a dialysis center for treatments 3 times a week rather than have her be involved in it.
Yeah, that is a lot to take on, even if you're super knowledgeable. Sometimes it's just too much stress for the family member, and if they miss a step, they would feel responsible if there was an infection or the treatment wasn't done correctly. So in that circumstance, it was probably best that he continue to go to the dialysis center.
Mm-hmm. Well, you mentioned a variety of people could be involved in giving medications, a next door neighbor, friend, family member, nurse. Mm-hmm. What kind of record keeping is done to prevent duplicate doses or missed doses?
Well, typically, there is computerized and paper. If it's myself coming in, most agencies or companies have pretty much gone to computerized, like say an iPad that you document all of this. As far as family members, there are notes that we can put in that computerized chart, but typically it would be something documented on paper that they log. So, it's consistent time, the, amount of time, what was it administered, to keep accurate records. And then when the nurse does come in to visit, we would record those.
If a neighbor, for example, was the one responsible for giving the antibiotic, then the neighbor would be checking in with the nurse, and the nurse would be checking in with the neighbor or the family to confirm that the doses were given according to schedule. Is that what you're saying?
Yeah, so typically on a visit that we would go, whether that be weekly or by every other week, we would speak with the patient to go through the neighbor, not necessarily directly, but involving the patient to get that, documentation or speak with them.
I'm thinking about risks, Shannon. I'm thinking about people who perhaps are not as comfortable with the concepts of sterile technique as we would like them to be if they're giving IV drugs. Tell us about, from a global perspective, as legal nurse consultants, what can we identify as risks that would accompany the decision to have home IV therapy?
Well, some of the risk, this isn't necessarily in any order, but maybe from the least severe to worst case. Infiltration is fairly common. So that's the leakage of your IV fluid into the surrounding tissues, causing swelling and pain and potential tissue damage. Extravasation is more severe than infiltration. It's where the IV fluid, particularly if it's a vesicant, leaks into the tissue, potentially causing severe damage. Then there could be a risk of infection. So that could be at the catheter site and or bloodstream infections, which can be life-threatening if not properly treated right away. Phlebitis, that would be an inflammation of the vein, leading to pain, swelling, redness, and an air embolism. That could be an introduction of air into the bloodstream, can be fatal if it reaches the heart or the lungs. And then lastly, anaphylaxis, which is a severe allergic reaction to the medication requiring immediate medical attention.
All right, so that's quite an impressive list, from fairly minor to life-threatening.
Mm-hmm.
Tell me, how does that influence what the home care nurse or the IV infusion nurse does in the way of teaching or reacting to symptoms that are concerning, as you just described?
Well, say if the family member does, I mean, of course, we educate on these things. They are instructed to call 911 immediately if it's, say, anaphylaxis, air embolism, and they have certain signs and symptoms. A lot of these patients either have IV Benadryl on hand or an EpiPen. But regardless, if there's something serious going on, they're always instructed to call 911 and then also call their home care nurse and provider.
As I think about the implications of this, when minutes count, that's a lot of risk that somebody's going to
Yes.
recognize the problem, follow through appropriately. I worked not on an IV case, but I worked on a case where a infant was at home. He was 7 years old. He, unbeknownst to anyone, had a growth that was growing to occlude the opening of his tracheostomy tube. And
Yes.
his home care nurse, who was an LPN, saw him gasping for breath and called the clinic. And the clinic said, call 911. And instead, she called the father, who was at work. And he drove 20 minutes to get home. And when he walked in, his child was dead.
Oh, boy.
Not an IV case, but a case where you've only got a few minutes to do the appropriate thing. There was a ambu bag at home. There was an emergency kit. She didn't know where it was. She didn't go for it. So I think about what you're describing, and I think that there's a potential for a catastrophe if the emergency is not handled correctly. What are your thoughts on that?
Well, we try to have them take vital signs pre, during, and post infusion, which isn't too terribly difficult if they have those devices at home, which typically they do. Also, in many of these cases, especially if it's a new therapy, of course, the nurse is going to always be at the initial visit, or they might do it the first dose in the doctor's office or the hospital to monitor if they're going to have a reaction. And generally speaking, if they do okay, it typically does not happen, but they still have that medication on hand the Benadryl, EpiPen, and the protocol of who to call, because it still could happen. It's not likely, but it still could. So a lot of ongoing education, check-ins, keeping that list or some type of documentation of what to do. Because of course, if you panic, you can forget a lot of these steps and who to call.
And how far are you away from the local ambulance? I know that you're based in Florida, where there are lots of people, lots of ambulances close by, but if you're in a rural area where it could be half an hour or an hour for somebody to be able to reach you, you're not going to survive an anaphylactic reaction. Before we continue.
Hello, I'm Barbara Levin, and I've been co-hosting the LNC Success Conferences with Patricia Iyer. Today, I'm joined with Nancy Stuck, who is a very seasoned legal nurse consultant and has served as an expert as well as a behind-the-scenes expert on multi-million-dollar cases. She has attended and presented at many of our conferences. Nancy, if you could share your thoughts on the value of our conferences.
Barbara, yes, I just want to invite everybody to these conferences. There's such a wealth of information, and it doesn't matter if you're starting, if you're in the middle, or if you're really seasoned, you always get something from these conferences. And the topics that they go from marketing to getting your first case to how to deal with attorneys, and it's just such great information, and it's really been helpful in promoting, helping me build my career.
And I know you've had many networking opportunities and have obtained cases that way as well.
Oh, absolutely, because it's virtual conference, you see people from all over, and you just get hooked up with these people and go into breakout rooms with them, and you get your next contact, your next case.
Thank you so much. We want you to join us at our next LNC Success Conference. Please see the link below. Look forward to seeing you.
And now let's return to the show.
That definitely is a much bigger risk. Yes, absolutely. If they're rural, the time, depending on where it is, it could be a little bit delayed in how they respond and the resources. So that is a concern.
Well, as we think about the risk, we talked about the clinical risks. We talked about the complications associated with IV therapy. Help our listener anticipate what would bring a person to a plaintiff attorney's office to say, my mother or father was receiving home IV infusion treatment and this happened. What kinds of stories, descriptions, and I don't mean stories in terms of fictitious, but what types of facts would they put into their explanation as to why they were looking for help? What are some of the things that we could anticipate they would be asking about?
So the plaintiff might bring a lawsuit for several clinical reasons related to this, which a first one would be negligence in care. So that's basically a failure to properly monitor and manage the IV therapy, leading to complications like infection, phlebitis, and infiltration. Just basically a failure to educate. So inadequate training provided to the patient or caregiver, resulting in errors in administering the infusion or managing the IV access. Delayed recognition of complications, failure to recognize and address signs of complications like sepsis, anaphylaxis, extravasation in a timely manner, and also improper insertion or management of that IV access that can lead to injuries like nerve damage, bleeding, and embolism.
And in your clinical practice, I know that you have encountered some of these complications. Is there a way to identify what might be the most common one that would cause a plaintiff to seek care from an attorney?
I would say when it gets really bad and there's, like say a permanent damage, an ongoing issue resulting from that, I think it would come down to like an anaphylactic situation, a septic situation, and or permanent damage to a nerve and extravasation, where a vesicant is in your tissues, and that can lead to necrotizing, the tissue and potential, going into, septic shock, and losing proper use of that limb potentially. So recognizing those signs of sepsis, anaphylaxis, is very important because it can quickly, like I said, lead into septic shock, organ failure, and death. So that early detection and intervention is very critical to prevent those severe outcomes from happening.
Do you ever encounter situations where you've provided the family with the education and you've gone through, here are the signs of anaphylaxis or septic shock, and they say, Shannon, I don't want to be involved in this. This is too much for me. I'm not signing on for this. Does that ever happen?
I would say more so than not, most people are not comfortable with that. It really usually boils down to they have a close family member that's a nurse, or the spouse is a nurse, or a niece. There's a limited amount that when these patients have been, say, on an ongoing biologic treatment for years, they become very comfortable, say, accessing their port, and very meticulous about, their technique to stay sterile, aseptic. I haven't seen many as far as trying to start their own IV. It's not completely impossible, but not ideal. But most of the patients that do this usually are a PICC line, more of a long-term implantable device that they're comfortable with accessing in the proper way so they don't give themselves an infection or any type of other complication. And then usually still a nurse will come in to do dressing changes. It could be weekly because typically the IV access, a peripheral IV, is just one and done. You're not going to leave it in there. So every time you go to the home, you're going to start a new IV. So what I've seen is usually the patients, whether it be adults or pediatrics, and when they're taught properly, do access their own port or say their PICC line access long term.
And then the other question that has occurred to me is that you could potentially be giving home IV infusion to somebody who has a addiction to street drugs. And now all of a sudden they have this wonderfully convenient access route that's sitting there 24/7 available to them to inject themselves with a variety of substances. Have you run into that?
I actually have a handful of times inpatient and home IV infusion. Generally, I think depending on your background and experience, I've quickly picked up on that and immediately have an alternative route, whether it be the hospital or in-home infusion, where the doctor's notified right away and that access is taken away. I mean, that compromises the patient on just about every risk in certain ways, besides just injecting themselves with a drug. Some of the long-term IV drug abusers, they're so used to accessing their own veins that they don't even really necessarily need that. But yes, that can be an issue. I don't see it all of the time, but I have seen it. And when I did, I basically refused treatment for that patient or administering anything, because you don't know what has gone in there, what type of reaction, if there's already infection going on. So you just immediately report it to the doctor and go from there. And if they're not compliant, I personally will not put the patient at risk or my license to continue treatment for that patient. So they would have to find another alternative, whether it be going in a facility or some type of other plan for their ongoing treatment.
Mm-hmm. Yeah, I can see the risks would be huge. My next door neighbor in Florida had an implantable morphine pump. And when his son came, who was from out of state, his mother and I were out having lunch. And when she came back, she found crowbar scratches in the frame of the doorway that contained the safe that had the morphine in it. Now, she knew he had a substance abuse problem, but she never thought that he would go after his father's morphine. And she managed, then she put it in the car, and she put the car in my garage with my permission, and the garage was locked so that she could keep him from trying to steal the morphine. Another thing that honestly had not occurred to me, I felt a little naive when I heard the story that a family member would try to steal morphine from a father. I don't know if you, in your experience, have ever run into that. To me, it was a brand new experience.
From my experiences, I've also been a medical device with intrathecal pain pumps and in the hospital working with PCA. And if they do go home on that, that's probably where I've seen the most tampering with, is when you have a family member, knowingly or unknowingly, they will try, most times than not, to access that drug. I've actually seen family members really being overly interested on how to maintain refill intrathecal pain pumps and accessing it themselves and taking drug out of that patient's intrathecal pain pump to basically shoot up themselves, which there's all kinds of issues that come from that, not to mention the patient's not getting their treatment and they can easily go into withdrawal, and that could cause death ultimately. And just the drug seeker retrieving the drug through somebody's a patient's skin, I mean, that poses for infection for themselves and clearly not ideal to happen. But I've probably seen that happen more than just about anything else we've talked about. Sadly.
It is sad. It's an incredible act of desperation.
Yes.
Is there anything else that you'd like to share with us that we haven't covered, Shannon, about this topic of home IV infusion?
Nothing I can really think of except for this last example, which went a little bit into intrathecal pain pumps. But I think the ability for patients to receive home IV infusion, there's a lot of pluses and positives because a lot of people do not have adequate transportation or the money to go into facility, because you can do outpatient infusion therapies where, of course, you have to make an appointment, go in, get your infusion, go out, and the convenience of it. Being in their home, if clean, is a lot better place for them to receive this anyways. Because they're exposed to other patients, the hospital, things can happen from that. So I think there's a lot to be said to have that option to receive therapy at home.
Yeah, that certainly is an important factor. I worked on a case of a woman who had a implanted hip removed because it started leaking the chromium after a while, the cobalt and chromium. And she ended up with an infection when the hip was removed and had to go, I think it was twice a week for 6 weeks, to a outpatient center to have her IV antibiotic. And it was a good 2.5 to 3 hour round trip plus the procedure itself, and tremendously inconveniencing if you were of working age, for example, and had to lose that much time from work or possibly lose your job because you weren't able to work to your full capacity.
Right.
I know that our listeners are going to have questions and will want to have you consult with them on these types of cases. I know you do expert witness work on this area. What would be the best way for them to reach? Shannon, I know that our listeners are going to be curious about how to reach you for help, either behind the scenes with a case involving home IV infusion, or they're considering hiring an expert witness when there is this type of complication that we've been discussing, one of the complications, what would be the best way for them to reach you?
Okay. First off, my email address, which is shannon@medlinkslnc.com. That is spelled SHANNON @MEDLINXLNC.com. My website is www.medlinkslnc.com, which again is spelled MEDLINXLNC.com, and my direct phone number to contact me is 817-235-1708. Pat, I just want to say thank you for allowing me to be a guest on your podcast, and I encourage any and all of your listeners to contact me anytime. I welcome that. Thank you.
Thank you, Shannon. It's been wonderful to have you as a guest, and you've given me some new thoughts about the risks associated with home IV infusion that I now see in a different light. I know that this podcast has highlighted some of the aspects of home IV infusion. Giving medications and fluids at home is something that may not have occurred to our listeners. You've highlighted some of the risks associated with the lines, with the anaphylaxis and septic shock in particular as being the most serious life-threatening risks associated with this procedure. And we've talked about the pros and cons. Certainly the convenience factor, the ability to be in your own home, not exposed to other people's organisms, is a consideration. However, there are also risks associated with the caretakers and their ability to manage this procedure and do it comfortably and aseptically.
Mhm.
So do contact Shannon when you have a case where this is an issue and you need some informed, educated, and experienced assistance. Hang on for just a few more minutes when we talk about what's coming up next on Legal Nurse Podcast. Coming up next on Legal Nurse Podcast, I'm going to be sharing with you a solo episode about 3 difficult client situations. You'll learn tips on how you can manage these situations so that you can be aware that they may exist and you know proactively how to handle them. The situations that I'll cover in the next podcast are evaluating where you can put your boundaries, setting up shields so that you are not constantly being contacted all hours of the day and night by your clients. The second issue that creates difficulties for legal nurse consultants, and these are big ones, are rate increases, scope creep, and rush fees. When you should increase your rates, how you should notify your clients, what to do when attorneys want to negotiate with you over your rate increase. Scope creep, when the attorney expects more of you than you're willing to give for the service that you have identified, and rush fees, when you should impose them, and how you should handle that dialogue. And then the third aspect that we're going to cover in this podcast is client fit. There are some clients who are very difficult to work with, and I'll share with you some strategies for managing the client fit problem. Be sure to come back for the next episode of Legal Nurse Podcast, in which I share with you how to handle some of these thorny issues that can affect your satisfaction as a legal nurse consultant, and how you can avoid the headaches associated with those problems. I'll see you then. Thank you for being part of our audience of Legal Nurse Podcast. I hope that you enjoyed this session and you got some great tips from it. I would love to see you at our February 2025 LNC Success Online Conference. That will be our 11th conference, taking place February 27, 28, and March 1. You can get your ticket by going to lnc.tips/February 2025 virtual. I'd love to see you there.